The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. One moment. Yeah. Good evening, everyone. Happy Teachers' Day to everyone as well. We are all teachers, and we have Ajay with us, taking us to another session of electrolyte. There was an electrolyte quintet in last Lancet many years back. So this is probably the third of the series of electrolytes here. I welcome you all into this. Dr. Ajay Kher, now we all know, is an alumnus from AIIMS New Delhi after his nephrology training in Harvard, Massachusetts, and a faculty position there. He had a stint at Fortis Escorts, and now he set up his clinic, Vishwanath Clinic in Noida, which of course will be visible on his email. Welcome, Dr. Ajay. We look forward to another exciting and crisp presentation on potassium homeostasis.
Thank you, Dr. Modi, for the introduction, and I'll kind of start my talk. So I'm going to be talking about the potassium homeostasis and the basics of potassium, and I'll divide it into 4 parts. We'll talk a little bit about potassium and the membrane potential. We'll talk about potassium and cellular shifts and how potassium is buffered inside the cell. Then we'll talk about potassium excretion and the handling by the kidneys. And then we'll talk with all of this about steady state and how homeostasis is maintained. I'll start with the potassium and the membrane potential. So the resting membrane potential is described by this equation, which is dictated by the potassium concentration inside the cell versus the extracellular compartment, and the sodium concentration inside the cell and the extracellular compartment. So any changes in potassium will lead to changes in the membrane polarization and membrane excitability. And it is this change in the membrane polarization and excitability which ultimately leads to all the symptoms that you get from hypokalemia or hyperkalemia, and which are predominantly neuromuscular with weakness and paralysis, or cardiac arrhythmias. So the main issue with hyperkalemia is related to the change in the membrane polarization. So now we'll talk about how potassium is distributed inside the body. So predominantly potassium is intracellular, and most of the potassium is inside the cell with 140 millicoulomb per liter and a 25-liter distribution for a normal 70 kg person. And this intracellular potassium is maintained by the sodium-potassium ATPase, which will push sodium outside the cell and bring potassium into the cell. The extracellular or the intravascular potassium is 4 to 5 millicoulombs per liter. So it is interesting to note that even if you drink 2 or 3 glasses of orange juice, it will have around 40 MEQs of potassium. And if that 40 MEQ is only equilibrated in the extracellular fluid, then your potassium will go up to 6 to 8 MEQs per liter. So what is imperative for the organism, or for humans, or for other organisms for the matter as well, is that they have to be able to take that oral load of potassium or IV load of potassium and be able to buffer it inside the cell. So the way the body buffers it is with the utilization of catecholamines, insulin, and then the increase in plasma potassium also helps in buffering and transitioning the potassium into the cell. Other things that cause shifts in potassium into or outside the cell are exercise, the pH or acidity or alkalinity of the blood, hyperosmolarity, and cell breakdown. So we'll talk about each one of those over the next few slides. So if we look at the total excretion of potassium from the body, that is going to be the job of the kidney, and it will try to match the intake to the excretion so that the body stays in potassium balance. And we'll talk about that after we go through the cellular shifts as well. So the catecholamines are predominantly the beta-2 receptors. They stimulate sodium-potassium ATPase. The beta-2 receptors also directly increase insulin release from the pancreas, and the beta-2 activity increases glycolysis, which increases glucose, which will cause secretion of insulin as well. And all of these activities increase the shifting of potassium into the cell and leading to buffering of the potassium. To see the impact of catecholamines, there's a couple of slides that I'll go over. So the first one is the study from 1980. In the left or the y-axis is the plasma increase in plasma potassium, and on the y-axis is time in minutes. And all of these subjects were given potassium infusion for the first 60 minutes, and some of them, which is the red dotted lines, were controls. And so the potassium goes up somewhere around 0.5 to 0.6 milliculons per liter by 60 minutes, and then the body buffers it, and the potassium comes back down to normal by 150 minutes. If they've already been on a beta blocker, which is the blue line, then the buffering of the potassium, or transitioning of that IV potassium into the cell, is hampered, and so the rise in potassium, serum potassium concentration, is higher, but it is still buffered. It's just that the buffering takes time. So one of the key things to note is that the potassium is still buffered, but it just takes a longer time, and the peak of serum potassium is going to be longer for those who are on a beta blocker. On the flip side, if someone is given a beta agonist, so this is now controls in the blue, and they're getting an epinephrine drip from 0 to 100 minutes. And there is a drop in potassium, which can be seen here, from about 3.8 going down to 3.2, and then they rise after the epinephrine is stopped. If the patients have been on a hydrochlorothiazide diuretics for 7 days before, compared to placebo, which is the control group above in blue, then the drop, the potassium starts from about 3.2, 3.3, and goes all the way down to 2.8. So one of the key things to note is that the beta agonists do cause a mild hypokalemia or drop in potassium, but it can augment other causes and other etiologies for hypokalemia, and then that combination can lead to significant hypokalemia. Another thing that causes shift of potassium into the cell is insulin. It promotes the potassium entry into the skeletal muscles and liver by increasing the sodium potassium ATPase. This is actually independent of glucose transport. And the main purpose or kind of teleological explanation is that whenever you're going to eat potassium in your diet, you're likely to take glucose with it as well in any kind of meal that you take. And so the insulin goes up with glucose, and it will buffer the potassium that is coming along with it as well. And another kind of thing is that we use it to treat hyperkalemia as well. Another thing that causes shifts in potassium into the cell is hyperosmolarity. So just to depict it, most of the potassium is inside the cell, and the water moves equilibrates across the cell membrane. So now if we increase the osmolarity to on the extracellular compartment to 350, what will happen is the water will move from the intracellular compartment to the extracellular compartment, and the intracellular compartment will shrink, which will cause the potassium concentration to increase. This increased potassium concentration will come out from the cell into the extracellular compartment through two mechanisms. One is the solvent drag. As water moves from the intracellular compartment to the extracellular compartment, the potassium will come along with it as a solvent drag. Or there is going to be passive movement down this increased potassium gradient, because now the potassium concentration inside the cell has increased, so the potassium will leak out along the gradient to the extracellular compartment. And so any hyperosmolarity, whether it is through glucose in diabetic ketoacidosis or any other hyperosmolarity, will lead to some potassium coming out into the extracellular compartment as well through these two mechanisms. So now let's look at what happens if you give glucose to a non-diabetic. So the red line is the non-diabetic. Let's start and focus on that. So if you give glucose to a non-diabetic, what will happen is as the glucose levels increase, insulin is being produced by the pancreas, and that insulin will cause a potassium shift. So the potassium will decrease, and the potassium decrease starts working within 60 minutes and will last up to 4 to 6 hours. So this is in the non-diabetics. When you give glucose to a diabetic and you don't change any insulin or you don't give any insulin, what will happen is the glucose will not be will not trigger an insulin release, and so the glucose will cause hyperosmolarity, and the potassium will leak from or leach from the cell and cause hyperkalemia or an increase in potassium due to the hyperosmolarity. So this is in response to the hyperosmolarity. So it's showing you the effect of hyperosmolarity and giving glucose in a diabetic without giving any insulin, while the red line is showing you what will happen if you give glucose to a non-diabetic, or if you give it with insulin as well. So one of the key kind of implications from this is that whenever we make someone NPO or keep them fasting overnight, it is going to lead to hyperkalemia. In non-diabetics, because the native pancreas is not going to make any insulin. And in diabetics, a lot of times we will stop their basal insulin or cut down their basal insulin, and that will also lead to some hyperkalemia. So one of the ways of preventing your morning before surgery, morning of surgery hyperkalemia is to give people when they're NPO a little bit of D5 at maybe 50 an hour or 35, 40 an hour, something like that, to make sure that there is glucose. So for the non-diabetics, their own insulin will kick in, and that we keep the basal insulin dose so that they don't get hyperkalemic if they're diabetic. So now coming to the pH or acid-base balance, which can also affect the potassium and shift in potassium between the cells. So the way it does is if you give H+ ion or cause acidity or increase the acidity in the extracellular compartment, H+ ions in the ECF will increase. These H+ ions will go and buffer inside the cell, and as H+ shifts into the cell will become positive charge, and to balance that positive, the potassium will come out. And so there will be potassium that will come into the extracellular compartment, and that is how pH and potassium are going to shift potassium across the cell membrane. Another mechanism of potassium coming into the extracellular compartment or increasing in the extracellular compartment is by cell breakdown. So the cells, each cell has 140 milliculons of potassium per liter, and so any trauma, tumor lysis, or rhabdomyolysis will lead to potassium increase and release into the extracellular compartment. On the flip side, anytime there is a sudden increase in cell production, potassium is going to be utilized in that, and so there can be hypokalemia that may happen with that. So if you give folate or B12 to a megaloblastic anemia, there can be cell may take up potassium in that. So just to summarize, so the cellular shift of potassium or the buffering of potassium that we take in our diet or through an infusion is done by catecholamines, insulin. Sodium potassium ATPase play a key role in that buffering. The plasma potassium concentration by itself also facilitates that buffering. And then there is exercise, pH, hyperosmolarity, and cell breakdown or production. So now we'll shift gears to the second part, which is how does the kidney handle the potassium excretion, and how does it maintain potassium balance. So there's a small loss of potassium in sweat and stool, but the main handling is done by the kidney, and it will adjust based on the total potassium intake, and how it does it is what we'll focus on. Majority of the potassium that is filtered is reabsorbed and then secreted in the distal tubule. The potassium secretion is regulated by aldosterone, the plasma potassium concentration, the distal flow, and sodium delivery. And so we'll go over each of these next. So this is a picture or a slide which shows potassium concentration or clearance by inulin clearance. and 1 means that there is no change, and potassium clearance is the same as inulin clearance. 0.1, which is here, means that all of the potassium has been reabsorbed. So this is the proximal tubule, and there is potassium reabsorption, but at the same rate as inulin. And then there is absorption in the proximal and the loop of Henle, and the clearance of potassium comes down to 0.1. So more than 90% of the potassium is reabsorbed by the time it reaches the distal convoluted tubule. These are the micropuncture studies that were done in 1966. And then in the distal convoluted tubule, you start having the potassium secretion, and it comes to the collecting ducts, and then this is in the distal convoluted tubules, and the collecting duct is where the modulation will happen, which will dictate how much potassium is being excreted in the end. So let's look at the principal cells, which are the key cells in the distal convoluted tubule, and how they secrete potassium. So we have the potassium, in the middle we have the principal cell, on the left side we have the tubular lumen, and on the right we have the peritubular capillaries. So the potassium is going down through the potassium channel, going down a chemical gradient, because the potassium concentration in the principal cell is higher, and the tubular lumen will have a lower concentration of potassium, so the potassium will come out. And then it will also depend on the number of potassium channels and how many of them are open, which will also dictate at what rate potassium is going to come out. Another feature is the ENaC channels, which are the sodium channels, and the sodium will get taken up into the cell through the ENaC channels. And then there is the sodium potassium ATPase on the basolateral membrane, which will take the sodium and put it into the peritubular capillaries and get 2 potassium in. This sodium potassium ATPase will also generate an electrical gradient, because 3 sodium are going out and only 2 potassium are coming in. So that creates a positive charge at the peritubular capillary side and a negative charge in the tubular lumen side. And that will also cause the potassium, which is a positive charge, to go down into the tubular lumen. So there is an electrical gradient causing the potassium to go and get secreted into the tubular lumen, as well as a concentration chemical gradient that is there. And this is maintained initially by the sodium getting reabsorbed through the ENaC channels, and then maintained by the sodium potassium ATPase, which keeps the sodium concentration inside the cell low, increases the potassium concentration by absorbing potassium from the peritubular capillaries, and makes an electrical gradient as well in the principal cell. So now let's talk about aldosterone. So aldosterone will, being a steroid, it will come into the cell through the cell membrane, bind to its intracellular receptor, and then it will activate all 3 of these pathways. So it will increase the activity of the sodium potassium ATPase, it will increase the ENaC channels, and so the increase in the sodium reabsorption from there, and it will increase the number and the number of potassium channels that are there as well, leading to increased potassium secretion. So aldosterone will act on all these 3 pathways. If aldosterone is not there, or someone has a fixed aldosterone level by replacement, potassium by itself, so the serum potassium or the plasma potassium concentration, will do all 3 of these things as well, increasing the sodium potassium ATPase, the potassium secretion through the potassium channels, as well as through the sodium reabsorption through the ENaC channels. And it will have the same effect if there is no aldosterone as well. And we'll go over some examples of that as well. So this is one of the studies which was done in 1983 on adrenalectomized dogs. And then they were given aldosterone supplementation. So we'll take each one separately. So on the left, or the y-axis, is the urinary potassium excretion. And on the x-axis is the plasma potassium concentration. So with the full circles or the black circles, what you have is this adrenal optimized dog was given a low dose sub physiologic aldosterone replacement, and then the potassium intake was increased to as high as 100 to 200 milliequivalents per day. And as you can see that the potassium is not being buffered as well, and the steady state potassium is continuously rising. And when you reach steady state, the potassium in someone who's not getting the physiological amount of aldosterone has increased now to 5.5 and 6. If they get their physiological amount of aldosterone, which is 50 micrograms per day, you can increase the oral potassium as much as you want and go up all the way up to 150 or even 200 MEQs per day. And the potassium excretion has increased without a significant rise in the serum potassium. So the potassium excretion increases without a significant increase in potassium concentration in the plasma. There is some increase, but not a significant increase, and will not lead to hyperkalemia. If you give supraphysiological doses of aldosterone, you start with a hypokalemic person, and with increase, you get some potassium rise, but again, it plateaus at around 4, and you cannot cause hyperkalemia by just loading them up with potassium unless you have hypoaldosteronism as well. So in the setting of hypoaldosteronism, you can have a high potassium intake leading to hyperkalemia. But with physiological or supraphysiological aldosterone, increasing potassium intake will not lead to hyperkalemia. So the higher potassium level that you get, it is within the normal range, and it is able, the kidney is then able to adapt and excrete the high amounts of potassium that you're taking as well. A similar study done in humans, in this, normal subjects were asked to increase their potassium intake from 100 MEQs to 400 MEQs a day. And this is kind of the potassium plasma level in green, the aldosterone level in red, and the urinary potassium excretion. And it depicts the baseline before they started this increase from 100 MEQs to 400 MEQs. And then it goes all the way up to 20 days, by which time they've reached a new steady state. And as you can see, is that their serum potassium started from somewhere around 3.8. It peaks at day 2 at about 4.5, and then comes down to 4.2. Their urinary potassium excretion increases tremendously and goes from 100 MEQs a day, where they were in steady state and balance with their 100 MEQ intake, and increases by day 20 to 400 MEQ. So they're now excreting 4 times the potassium that they were taking in before, and have matched the intake, and they're now in steady state. And as you can see, the aldosterone initially for the first 2 days increases, but by the time you reach steady state, the aldosterone is now completely normal, and the only driver of the potassium excretion of 400 MEQs is this slight increase in serum potassium of 3.8 to 4.2. So one of the corollaries is, as noted in the previous slide as well as in this slide, that just by increasing your potassium intake, you will not get hyperkalemia. You have to have some impaired excretion to develop hyperkalemia as well. Just loading potassium by itself in a normal person will not cause hyperkalemia, because the kidney has tremendous reserves and a tremendous capacity to initially use aldosterone, and then just this slight increase in serum potassium is able to drive the urinary potassium excretion to increase manyfold. Another part of control of potassium excretion is the distal tubular flow and sodium delivery. So this is another study in which they looked at the different levels of potassium diet. On the y-axis is the potassium secretion in nanomole per minute, and on the X-axis is the distal tubular flow in nanoliter per minute. And what is important to note is that when you're on a low potassium diet, this low potassium diet is going to cause hypokalemia. And in that situation, increasing the distal tubular flow does not make any impact on the potassium at all. And the potassium is not going to come out. And that is different compared to if you're on a normal diet or a high potassium diet, in which case you have a high plasma potassium. Because of the high plasma potassium, the aldosterone is going to be high. And in that setting, if the distal flow increases, you're going to get a high potassium excretion rate and a high potassium secretion. So the distal tubular flow is only going to impact the potassium excretion if there is high aldosterone and high potassium, or a combination of the both. So the impact of that is that in situations where, let's say, you just take a high salt and fluid intake, it will cause high distal flow, but it will not lead to hypokalemia, because the aldosterone from that high volume intake, aldosterone will shut down, and so there will not be hypokalemia because the aldosterone is low. Or on the flip side, if you have volume depletion, that will not lead to hyperkalemia because the distal flow will be low, but the aldosterone will increase. So you're able to maintain in both those situations your potassium balance, because the distal flow and the aldosterone are working at counter purposes and maintaining the potassium balance. However, if you give diuretics, whether loop diuretics or thiazides, you now have high distal flow, you have high sodium delivery to the distal tubule, and you have high aldosterone because you've caused volume depletion. So in that setting of high distal flow, high sodium delivery, and high aldosterone, now you will get hypokalemia. So now just one last slide about steady state, and this is about thiazide diuretics, and I've used this slide in the hyponatremia talk as well. And what it shows is that someone who's been on a hydrochlorothiazide for 100 milligrams a day for for normal subjects, for the first 3 days you lose sodium, which is in the gray bars, you lose potassium, which is in the red bar, and the sodium balance actually comes back to near normal by the next few days, and you're not losing sodium at all after the first 3 days. The potassium loss does continue to happen up to about 7 to 10 days. But after that, you're now back in steady state. And you've lost some potassium, which will remain out of your body. Your potassium level will be slightly lower. So if you started off, let's say at 4, you're probably now at 3.7 or 3.8. Whatever that potassium is, you're now in steady state, and you're going to maintain that. So if someone has not developed hyponatremia or hypokalemia from a specific dose of hydrochlorothiazide at 1 week or 10 days, they're not going to develop it at 1 month or 2 months or 6 months or 1 year, unless something new happens. So either you increase the dose, you add something else, then they may have either hyponatremia or hypokalemia. But once they've reached steady state, they will remain in steady state unless something new happens. So that is something to keep in mind as we talk about steady state with potassium balance, which is the same and a similar concept as for sodium and water balance as well. So just to kind of highlight it, so this person, before they took their thiazide, their potassium excretion forces and potassium retention forces were in balance. When they took their thiazide, potassium excretion took over, there was a potassium loss, and then the potassium retention forces will increase, so aldosterone will go up, the hypokalemia will drive potassium retention as well, and then they come back into balance, which is what happens by day 10. And this will be at the cost of some potassium that is lost from the body, and the serum potassium will be slightly lower, but it will and can still be within the normal range. So someone might start from 4, might get down to 3.7. So just to summarize the basics of potassium balance, the initial potassium load, whether it's oral or IV, has to be buffered, otherwise it can cause severe hyperkalemia. and it is buffered through catecholamines, insulin. The initial increase in the plasma potassium also helps in buffering, and the pH. And then the kidney has to excrete the daily potassium intake and maintain homeostasis, and that depends on and is maintained by the aldosterone, again the plasma potassium concentration by itself, and distal flow and sodium delivery also impacted. So I would like to acknowledge Dr. Burton Rose, Dr. Vijay Kher, and Dr. Jha for and I'll take any questions.
Thank you, Ajay. Can you hear me?
Yes.
Thank you. That was very nicely put, and it was contextualized very beautifully. I just have a question. When you say thiazides would be causing or contributing to hypokalemia within a week or two, in clinical situations, we do see patients getting hypokalemia or hyponatremia anytime while they are on hydrochlorothiazide-based antihypertensive treatments, wherein one could speculate only that their water intake had changed or their salt intake had changed. Would you think that that also constitutes one of the things as a change?
So if you look at the many times what happens is that people, after they've been put on a thiazide, their labs have not been checked for weeks or months on end. So it is important to make sure that you had at least one lab check somewhere around 10 to 15 days after you've put them on a specific dose of hydrochlorothiazide. If you increase the dose, then they have to set up a new steady state. So they may have tolerated 12.5, but whether they will tolerate 25 or not may be a different question and different answer. If they've been on a specific dose of hydrochlorothiazide, did not develop hyponatremia or hypokalemia, and then they develop it weeks or months later, something new has happened. Whatever new has happened will be, for each individual person, it may be different. It may be that they've suddenly been told they have kidney stones and they're now drinking 6 liters of water, and so they're now hyponatremic where they weren't that before. Or whether it might be some other medicine or something else that their intake has changed. But something has to be different. If they were in steady state and their sodium and potassium is normal, on that specific dose of hydrochlorothiazide, it should not develop out unless something new happens.
Great, thanks. Another, on taking it a little further, if you challenged somebody or a model on thiazide 6 months down the line for dilutional capacity, the dilutional capacity of kidney also comes to normal, or it remains subnormal all along?
So if you look at the people with hydrochlorothiazide who develop hyponatremia, so I think this is something which is a very well done study. So in what they did in a study, I haven't put it in this because this is predominantly potassium talk, is they took patients who developed hyponatremia on hydrochlorothiazide and they re-challenged them with a single dose. And they compared them to people who had been on hydrochlorothiazide and had not developed hyponatremia. And what they found was that the people who have hyponatremia with hydrochlorothiazide actually maintain their weight for the first 24 hours, while everyone else loses weight. Both of them lose sodium, but the ones who get hyponatremia actually maintain their weight. So whether the reason they maintain the weight is because there is a thirst drive that drives them to drink more water, or whether it is that they at baseline drink more water, whatever that reason is, that's not clear. But for some reason, those patients who develop hyponatremia from hydrochlorothiazide maintain their weight over the first 24, 48 hours, and they gain water. And that is what drives them to hyponatremia. So the mechanism actually, even a single dose challenge will tell you and can prove who is going to get hyponatremia or not from hydrochlorothiazide.
Right, great. We have a question from Dr. Bhanu Mishra. And if somebody develops hyponatremia with thiazide and we continue it, will he develop steady state?
At some point he will. How low that sodium is going to be different for different people. And whether you have picked him up in the steady state, I don't know. But they should reach a steady state at some point. But it might be a dangerous level of steady state, but they should reach steady state at some point.
We have a question from Dr. Subal Pradhan. Do we need to monitor sodium potassium in a patient on chronic thiazide therapy beyond 7 to 10 days?
No. So if someone's been stable and you've checked a sodium and potassium at 10 days, there is no reason to keep checking it every 1 month, 2 months, or 3 months. So if, let's say, someone is a hypertensive, you have him on a 25 milligram hydrochlorothiazide dose, you've checked it at, let's say, 2 weeks. Whatever you would do for a hypertensive on, let's say, a calcium channel blocker or an ACE inhibitor, and you would say, I just need to check them every 6 months or 1 year, the same thing you can do for someone who's on hydrochlorothiazide as well. There is no need to check once they are in steady state. Unless something new happens, they will remain in steady state.
Dr. Ashutosh Oja says, very nice presentation. Thiazides, different agents have different excretion rate. And does this mean that we will have to be watchful differently or for longer period?
So yes, hydrochlorothiazide, chlorthalidone are different in terms of their means the strength of action as well as the hypokalemic effect. Chlorthalidone is likely more hypokalemic, lasts longer, has more of a 24-hour action. But again, the impact is going to be within the first 10 to 15 days. And so as long as you're now in steady state, you're in steady state. So if you have someone who you want to put on chlorthalidone and you check him after 15 days and his sodium potassium is normal, you're done.
Great. Dr. Jayinder Singh says he enjoyed the lucid talk. At what level of GFR or creatinine would you avoid giving ARBs or ACE inhibitors to avoid hyperkalemia?
So again, that's a very difficult question to answer. I would say that there isn't a lower limit by GFR that I would say that you can't give ACE or ARBs. I would say the benefit is there all the way down. It's something that each nephrologist, I think, will have a comfort level of where they feel, and it's going to be on the potassium as well. So whatever the potassium is, and then if you want to continue the ACE and ARB, you can add some diuretics. So usually a loop diuretic can help maintain their potassium and then allow you to continue your ACE and ARB. But if you're running into repeated hyperkalemias with potassiums in the 6s and 7s, then at some point you're going to have to give up on the ACE and ARB.
Brilliant. We have no more questions, but I would invite audience, should there be any more questions, please put it into the question box. Ajay, I think there were no more, but very nice and crisp, enjoyable, and kind of revision of all basics of hyperpotassium balance and thiazides, as well as practical issues. Another question has popped in, Dr. Bhanu Mishra, role of ACE and ARB as hypertensives in CKD. Perhaps he means antihypertensives, especially ESRD.
Yeah. So absolutely something that should be used for all CKD patients. ACE and ARBs would be one of the first line therapies. And even in dialysis patients, sometimes means the dialysis patients are actually easier to use because the hyperkalemia is not going to be an issue because their residual renal function is already pretty low and they're going to get dialyzed as well. So in those patients also, you can use ACE and ARBs. There's no reason why you can't. It's mostly the people who are almost close to dialysis but not on dialysis where you will have to be monitoring them a little closer and using diuretics to make sure that they don't develop hyperkalemia. But there's no reason why you can't use it in people with advanced CKD as well as people on dialysis.
Great. Thank you, Ajay. We have no more questions. Thank you, everyone, for attending. We would close this webinar here. Everybody have a good evening. Any more comments?